Okay, it's 4:02. Welcome again to the Botswana COVID-19 webinar series, Thursday, 8 July. Today's topic is complications of COVID-19. Of course, we are within the third wave. We know that the Delta variant is causing waves across different areas in the globe, and of course, the Lambda variant is also emerging. My name is Dr. Palai. I'm with the University of Botswana. I'm a fellow in pulmonary and critical care medicine. And as usual, we go through our introductory slides to go through the house rules. So this webinar is co-organized by Ministry of Health and Wellness, University of Botswana, Botswana Harvard Partnership, and Rutgers University. You can join the mailing list by emailing Vusi at vindaba@globalhealth.rutgers.edu. Please do share with your colleagues across different parts of Botswana. The sessions are over Zoom, as you can see. We do kindly ask that you mute your microphone during the time when the speaker is giving it the talk. And you can ask questions using the chat function, and the moderators will actually monitor these questions and respond if they can. And if not, our speaker will be able to answer these questions towards the end. Okay, these sessions are recorded and made available after each of these sessions. They are fully recorded, and you can search for them on YouTube. I will show you that in a bit. And we do appreciate feedback. We do want feedback. Give us suggestions on how we can make these sessions better. And also we want topics or speakers that you want to come in and speak on these sessions. Next slide. So like I said, these sessions are available on YouTube, Project Echo COVID-19. We've had these sessions since last year at the beginning of the pandemic, and we've had several sessions ranging from oxygen therapy to therapeutics. We've done mechanical ventilation. We've done management. We've done contact tracing. We've done case definitions. So please do go and look at these definitions according to the Botswana guidelines. Next session. Next slide, sorry. So this is a very, very important website, the COVID-19 portal.gov.bw. This gives all the information with regards to Botswana with COVID-19. And I think in terms of clinicians or healthcare workers, the most important is the document library. When you click on it, you will see that a whole host of guidelines actually appear. These are guidelines on adult management in Botswana, guidelines on pediatric management, guidelines on how to open a center, how to do contact tracing, how to advise people within a district to actually open a center. Next slide. So this is what appears actually when you click on the document library. All these are available, and you can actually download and share with your hospital, your health post, your clinic. And it's very, very important that you go through these so that as things change, you are able to keep up and see exactly what is being done. Next slide. And on to today's talk. Like I said, today's talk will be on complications of COVID-19. We are privileged to have a distinguished speaker, Dr. Habib Rehman. Dr. Rehman is actually one of the doctors that is currently practicing in the UK. He graduated with an MBBS at Khyber Medical College in Peshawar, Pakistan, and became a fellow in the Royal College of Physicians Ireland in May 2004. He's been a consultant physician in general internal medicine and geriatric medicine in Broomfield Hospital in Essex in the UK. He's done that between 2003 and 2006. And he's a clinical associate professor in internal medicine in Regina Coyapel Health Region in Saskatchewan, Canada. He's also a clinical examiner with the Royal College of Physicians for the membership examination. He's been instrumental in the establishment of the teaching unit at the regional hospital in Saskatchewan, and and he's the Assistant Program Director as well in the Internal Medicine Residency program in the University of Saskatchewan. He's authored over 100 articles in peer-reviewed journals. He's also actively involved in charity work and has led medical missions in Indonesia following the tsunami disaster in 2004, as well as Haiti. We know that Haiti has had several disasters, but he's been instrumental following the earthquake in 2010, including organizing a fund collection dinner for which he collected more than $11,000. He's also a fellow in the Royal College of Physicians in Canada, which he joined in June 2008, as well as a fellow in the American College of Physicians, which he joined in 2011. Again, such a beautiful bio, Dr. Rehman. We welcome you, and the floor is yours.
Thank you very much, Dr. Palai, for a very kind and generous introduction. I am grateful to the faculty of Medicine, University of Botswana, and the SKMTH Botswana-Rutgers Partnership for Health for inviting me to talk to this August gathering here. As you know, the topic of the discussion is complications of COVID-19, which is a very current situation, which is changing every day. We are learning about COVID-19, about its pathogenesis, about its complications almost on a daily basis. So it's an ongoing learning process. I will try to summarize the knowledge that we have so far about the complications of COVID-19. The aim of this, Vusi, can we go to the aim slide, please? The aim of this this talk will be to anticipate and treat complications of SARS-CoV-2, which causes COVID-19, and then to stimulate research into this poorly understood disease, which is a relatively new disease, only discovered about a year and a half ago. So the causative organism is SARS-CoV-2, severe acute respiratory distress syndrome, coronavirus 2. It causes the disease COVID-19, and it has caused widespread morbidity and mortality on an unprecedented scale globally. Over 185 million people have been affected, and over 4 million deaths have been recorded so far. The scientific and clinical evidence is still evolving on the subacute and long-term effects of COVID-19, and obviously it affects multiple organ systems. The early reports suggest the residual effects of SARS-CoV-2 infection, like fatigue, dyspnea, chest pain, cognitive disturbances, arthralgias, and decline in quality of life, cellular damage, a robust innate immune response with inflammatory cytokine production, and a procoagulant state induced by the SARS-CoV infection may contribute to these infections. Lucy, are you following? Are you in line with me? The slides?
Yes, sir.
Okay, so I'm on the next slide now, which is quite a busy slide. It's a diagram. Lucy, is that the slide we are showing?
Yes.
Okay, so this is the brief definition of what the timeline is of post-acute COVID-19. It's still evolving. It has been suggested to include persistence of symptoms or development of sequelae beyond 3 or 4 weeks from the onset of acute symptoms, since replication-competent virus has not been isolated after 3 weeks. So 3 to 4 weeks is considered, or beyond 3 to 4 weeks is considered the post-acute stage of COVID-19. For the purposes of this presentation, post-acute COVID-19 is defined as persistent symptoms and or delayed or long-term complications of SARS-CoV-2 2 infection beyond 4 weeks from the onset of symptoms. It is further divided into 2 categories. One is subacute or ongoing symptomatology of COVID-19, which includes symptoms and abnormalities present from 4 to 12 weeks beyond the acute COVID infection. And number 2 is the chronic or the post-COVID syndrome, which includes symptoms and abnormalities persisting or present beyond 12 weeks of the onset of acute COVID-19 infection and not attributable to an alternative diagnosis. Next slide. Now, during these there are early reports have now emerged on post-acute infectious consequences of COVID-19 with studies from the United States, Europe, and China. This is an observational study from 38 hospitals in Michigan, evaluated the outcomes of 1,250 patients discharged alive at 60 days. During the study period, 6.8% of the patients died. 15% of the patients required readmission, and of the 488 patients who completed the study, 32%, which is about 1/3 of the patients, reported persistent symptoms. The most common complications or the symptoms in the post-COVID syndrome are dyspnea on exertion in about 1/5 of the patients, cough, persistent loss of taste and smell. And these were the common symptoms in these patients. Similar findings were reported from Italy. This study reported persistence of symptoms in 87.4% of the 143 patients discharged from the hospital who recovered from acute COVID-19 at a mean follow-up of 60 days from the onset of the first symptom. Fatigue, dyspnea, joint pains, and chest pains were the most common symptoms, commonly reported symptoms. 44% of the patients reported worsened quality of life. So recovery from acute COVID disease is a good news, but it is followed by these symptoms in quite a significant proportion of these patients. Next slide. In a cohort study from Wuhan, a comprehensive in-person evaluation of 1,733 patients at 6 months from the onset of symptoms, 76% of the patients reported at least one symptom. The most common symptoms, again, were fatigue, muscle weakness, sleep difficulties, and anxiety or depression. Next slide. In another study, around 1/3 of people in England who developed COVID-19 went on to experience long-term symptoms. And
I think I lost you. Which slide are you on?
This is slide number 18 on my side.
And what does it say?
It says around 1/3 of the people in England.
Right. Okay. We are there.
Okay. So this is a study which showed about 1/3 of the people in England who developed COVID-19 did experience long-term symptoms after the recovery from the acute event. They call it long COVID, and experts believe that over 2 million people could have been affected in this way, which in all likelihood has increased since then because of the many more infections that have been recorded. Next slide. Severity of illness is the main factor which is associated with the presence or persistence of symptoms. Now, severity of illness is measured by admission to an intensive care unit and or requirement for invasive or non-invasive mechanical ventilation. So those patients who required either ventilation, invasive or non-invasive, or required intensive care unit treatment were at a higher risk of developing these post-COVID complications like fatigue, dyspnea, weakness, post-traumatic stress disorder, and as we will talk about, pulmonary function test abnormalities, radiographic abnormalities, etc. Other additional associations have also been found. Halpin et al. Reported additional associations, and these were pre-existing respiratory diseases, higher body mass index, older age, Black, Asian, and minority ethnic population, and patients who report dyspnea at 4 to 8 weeks follow-up after recovery from the acute infection. In a post-acute COVID-19 Chinese study, it was also suggested that sex differences, with women more likely to experience fatigue and anxiety and depression at 6 months follow-up, which is similar to the SARS survivors. Next slide. In a study called REACT-2 study from Imperial College London, which used self-reported data from over 500,000 adults aged between 18 and older, took part in 3 rounds of surveys between September 2020 and February 2021. And they were asked about 29 different symptoms. Next slide. They found that around a fifth, about 20% of these surveyed reported having had contracted COVID-19 previously, with more than a third, about 40%, nearly 40%, reported at least one persistent symptom, and around 15% of them experienced 3 or more symptoms lasting at least 12 weeks. Next slide. In the same study, about a third of people reported severe COVID-19 symptoms that had significant effect on their daily lives. So these symptoms mostly were shortness of breath, joint pains, chest pains, etc. 5.8% of the study population, which is the population was more than 500,000 people, had more persistent symptoms for 12 weeks or more. And again, the most common symptoms were shortness of breath, tiredness, muscle aches, and sleep disturbances. Next slide. This is slide 25 on my list. In addition,
Yes.
the researchers also found that long COVID was more common among women, 1.5 times more likely, and people who were overweight, obese, who smoked, lived in deprived areas, or had been admitted to the hospital, as in the other study I mentioned before. Next slide. This is in contrast to the previous finding in another study. The persistent COVID-19 symptoms were lower in people with Asian ethnicity, although another study had found that they were at higher risk along with Black people and other ethnic minorities. Next slide. So these studies that we have looked at so far also suggested that increased prevalence of these symptoms with increasing age, and 3.5% increase in likelihood of persistent symptoms or post-COVID complications for each decade of life. This is a busy slide, and the next one is also a busy slide. So I will just go through it quickly. Slides number 28 and 29. It gives a rough, it gives an estimate of the prevalence of the different symptoms in these different research studies. So these symptoms basically included fatigue, joint pains, muscle pains, dyspnea, cough, chest pains, palpitations, anxiety, depression, sleep disorders, loss of taste and smell, headache, etc., etc. The next slide is a summary of acute and post-acute COVID-19 by organ system, which is slide number 30 on my side. So we'll start with the pulmonary system, the respiratory system. So the most common, a spectrum of pulmonary manifestations ranging from dyspnea with or without chronic oxygen dependence to difficult ventilator weaning and fibrotic lung damage has been reported among COVID-19 survivors. I still have 2 patients on my ward who were admitted round about May time, when we're in ICU, they are still on high flow oxygen. They have developed pressure sores, quite bad. We are unable to wean them off oxygen. So there are few patients who linger on and develop these complications. So, but more commonly, the patients go home, but they are bothered by these symptoms of dyspnea, decreased exercise capacity, etc. Dyspnea is the most common persistent symptoms beyond acute COVID-19, ranging from 42 to 66% of patients in a 60 to 100-day follow-up. We don't have longer follow-ups for these patients yet, but studies are in progress. As time goes on, we will have more information on the long-term complications of COVID-19. The need for supplemental oxygen due to persistent hypoxemia. This is the next slide, Lucy.
Yes.
The need for supplemental oxygen due to persistent hypoxemia or new requirements for continuous positive air pressure or other breathing support while sleeping was reported in 6.6 and 6.9% of patients at 60-day follow-up in post-acute COVID-19 US study. So a small proportion, but a significant proportion of these patients do require long-term oxygen support. Next slide. A reduction in diffusion capacity is the most commonly reported physiological abnormality in post-acute COVID-19, with significant detriment directly related to the severity of acute illness. So the more severe the acute illness was, these patients were likely ICU patients. They have persistent reduction in diffusion capacity. Next slide. Apart from reduced diffusion capacity, restrictive pulmonary physiology and ground glass opacities on radiography, fibrotic changes have also been reported at follow-up in these patients and these survivors. Next slide. In a single center cohort study, outcome data showed that the lungs were often physiologically and radiologically impaired at 3 to 4 months after hospital discharge. Next slide. In one study from Italy, the diffusion capacity for carbon monoxide was below normal range in 52% of the 238 patients at 4 months, which is a very high proportion of these patients and at a reasonable distance from the acute illness where you would have expected them to have fully recovered, but they have long-term damage to the lungs. And similarly, a study from Canada found 55% of patients had CT evidence of radiological abnormalities at 12 weeks after discharge. Next slide. A French study reported similar findings with evidence of fibrosis in 12% of patients and 37% of non-intubated and intubated patients. So the intubated patients had a higher prevalence of radiological evidence of lung damage or fibrosis than the non-intubated patients. Next slide. Again, in a cohort study from Wuhan, China, severity of acute infection correlated with the percentage of patients with the carbon monoxide reduction 6 months after discharge. So again, the more severe the illness is, the acute illness is, the more likelihood of long-term symptoms and damage. Next slide. Now, data on longer-term post-COVID sequelae remains sparse, although a small prospective study from Wuhan looked at respiratory outcomes over the course of a year after hospital discharge. Next slide. And the percentage of the patients with radiological abnormalities fell from 78% at 3 months to 27% by 9 months, but then remained unchanged at 12 months. So that may mean that there's a slow improvement, may take up to a year, but then again, there's a significant proportion of patients, roughly about 1/4 of them who have persistent abnormalities at 12 months. Next slide. In this year-long Wuhan study, ground glass opacification at 9 months was still present at 12 months in these patients, which raises the possibility that it may represent pulmonary fibrosis as a permanent complication of the lung damage they have sustained during the acute illness. The other main pulmonary complication is obviously the pulmonary embolism, which is common in patients with acute COVID-19. But it also found that increased incidence of venous thromboembolism 200 days after the acute illness. So after recovery from the acute illness, there is still significant risk of developing pulmonary embolism or a thromboembolism in some of these patients. Next slide. In a small pilot study from UK, they used hyperpolarized xenon magnetic resonance imaging of the lung and found that regional diffusion abnormalities were persistent for 3 months after hospital discharge, even in those patients with near normal CT scans. These findings may indicate enduring pulmonary vascular abnormalities after acute COVID-19, but further investigations are required, and clinical significance of these abnormalities is still unknown. I think with further research and further time, it will become obvious. Next slide. So how do we manage these pulmonary complications? At the moment, we need to keep an open mind and monitor these patients. It may include home pulse oximetry, 6-minute walk test, pulmonary function test, CT, chest with CT angiogram, etc., on these patients who have persistent symptoms. Next slide. From respirology, we will move to hematological complications of COVID-19. And again, the increased inflammation secondary to the infections leads to severe instability of hemostasis in these patients, which is often seen in patients with sepsis. Next slide. The severe inflammatory state has been described as an acute DIC, and it's quite common in sick patients in COVID wards. It's characterized by reduced platelet count, prolonged PT and APTT, increased fibrinogen degradation products, FDPs, and elevated D-dimers, as well as low fibrinogen levels. Next slide. In this study of 183 consecutive patients, 11.5% patients died. 42.6% were discharged, and about 46% were still in hospital on the last day of the follow-up. Next slide. Of the total, 71% of the patients who died met the International Society Thrombosis and Hemostasis criteria for DIC, compared with only 0.6% among those who were discharged alive. So DIC is a very poor prognostic sign. Next slide. Compared with the influenza A H1N1 pneumonia in 2009 pandemic, the microthrombi in the alveolar capillaries has been reported 9 times more common, more prevalent in lungs in COVID-19 who died with respiratory failure. So yes, anybody who is sick enough will develop or is at risk of developing thromboembolism, but these patients with COVID-19 are at much higher risk than other conditions causing similar level of sickness or sepsis. Next slide. Thromboembolic events have been reported in less than 5% patients in post-acute COVID-19 in retrospective studies. And next slide, a single study of 163 patients from United States suggested a 2.5% cumulative incidence of thrombosis at 30-day follow-up discharge. These included segmental pulmonary emboli, intracardiac thrombus, and thrombosed arteriovenous fistulae and ischemic strokes. So again, 2.5%, although is a small proportion, but large numbers, looking at the numbers which are affected, are at risk of these thromboembolic complications after recovery from acute illness. And the median duration of the next slide, the median duration of these events was 23 days post-discharge. Next slide. The exact mechanism of this higher risk of thromboembolism is not known, but decreased levels in protein C, protein S, and antithrombin 3 levels have been detected in addition to antiphospholipid antibodies in COVID-19 patients. And all of these may play some role to some extent in the development of thromboembolism in these patients. Next slide. The duration of hyperinflammatory state induced by the infection with SARS-CoV-2 is unknown. So we don't know how long these patients are at risk of or remain at risk of thromboembolism. Next slide. How do we manage these conditions? Again, direct oral anticoagulants and low molecular weight heparin may be considered for extended periods of time as a thromboprophylaxis. And then obviously have to be individual patient-based, depending on their risks and their immobility and their D-dimer levels, et cetera. So the patients who are at higher risk, for example, they are immobile or they have other comorbid conditions like cancer, which increase their risk of thromboembolic episode, may require longer thromboprophylaxis with either low molecular weight heparin or with direct oral anticoagulants. Next slide. We come to the cardiovascular complications, and among hospitalized patients with COVID-19, acute cardiac compromise is common. This is the acute setting, and this includes acute heart failure, cardiogenic shock. Next slide. Myocardial ischemia or infarction, ventricular dysfunction, left, right, or biventricular. Next slide. Stress cardiomyopathy, also called Takotsubo cardiomyopathy, arrhythmias, venous thromboembolism we have already talked about, and arterial thrombosis secondary to viral mediated coagulopathy. But right ventricular dysfunction is the most common echocardiographic finding in these patients. In one study, around 40% of these patients had a right ventricular dysfunction, likely secondary to the extensive involvement of the lung due to the virus. Next slide. In a series of 100 hospitalized patients, right ventricular dysfunction was also the most common abnormality in a multi-center international study, over 300 hospitalized patients with COVID-19, so around 26%. Next slide. Dysfunction of the global dysfunction of the heart can be seen, but you can also see regional left ventricular systolic function abnormalities, diastolic dysfunction, and pericardial effusions. Now, that was the acute COVID illness, but post-COVID cardiovascular complications are also common, and they include atypical chest pains, about 1/5 of the patients, palpitations and 20%, and dyspnea in about 1/3 of patients. So persistent dyspnea is again a common symptom, both due to cardiac and respiratory pathologies. Next slide. So In another study, they found that myocardial fibrosis or myocarditis was reported in 9 to 78% of patients recovered from acute COVID-19. So that's a worrying finding. Cardiac myocytes have ACE2 in receptors on their on the microvasculature, so that will explain some of the damage, persistent damage, myocarditis or myocardial fibrosis. But there are other mechanisms as well, including microthrombi, autoimmune processes, etc., etc. Next slide. Among 100 post-COVID patients who underwent CMR 2 to 3 months after the diagnosis, cardiac involvement was found in 78% of these patients, with ongoing inflammation in 60% of these patients. And recovered patients have the lower left ventricular ejection fraction and higher left ventricular volumes compared with risk factor matched controls. So again, persistent cardiac abnormalities are not uncommon. And these long-term sequelae may include, next slide please, increased cardiometabolic demands, myocardial fibrosis or scarring, detectable on cardiac MRI, arrhythmias, tachycardias, autonomic dysfunction. Next slide. So again, what to do with these patients? Again, serial clinical echocardiograms may be one way to go and see if their findings improve with the time, and electrocardiogram follow-ups as well. And obviously treatment depending on the findings. We'll talk about neuropsychiatric complications of, so next slide, Vusi. So these patients usually have complications involving the CNS, and it may be due to direct invasion of the virus, but also para-infectious processes like specific immune responses may be important contributors to the neurological symptoms. Thromboembolic episodes also, I think, are quite significant cause of some of these complications. Next slide. Most common neurological complications are headaches, dizziness, loss of taste and smell, encephalitis, encephalopathy, and cerebrovascular disease. Next slide. Seizures, neuromuscular junction disorders like Guillain-Barré syndrome were reported as a complication, as well as neurodegenerative and demyelinating disorders in some studies. Next slide. Again, there are reports of autoimmune encephalitis, memory loss, sleep disturbances, mood disturbances, and persistent headaches following acute infection. And this is in the weeks to months following an acute infection. Next slide. So the persistent abnormalities may include fatigue, myalgias, headaches, autonomic dysfunction, and cognitive impairment. They often complain of a brain fog. Next slide. Anxiety and depression is very common, and about roughly 30 to 40% of patients complain of persistent post-traumatic syndrome-like symptoms and are actually depressed and suffer from anxiety. Again, the pathophysiology, next slide. The pathophysiology of these neuropsychiatric complications is diverse and may include immune dysregulation, inflammation, microvascular thrombosis, and the effects of the medications, etc., used in the treatment. We'll talk about renal complications. In an acute setting, more than 20% of hospitalized patients and more than 50% of the patients admitted to intensive care unit have acute kidney injury. And an acute kidney injury was, next slide, an acute kidney injury was seen more commonly in hospitalized patients with COVID-19 than those without the infection, was more often associated with need for dialysis and was less likely to recover. So again, involvement of kidneys or an acute kidney injury is a poor prognostic sign in these patients. They are less likely to recover. Next slide. So observational cohort studies have reported need for renal replacement therapy in up to 20 to 25% of individuals with acute kidney injury from this infection. Next slide. And again, it's a poor prognostic sign and associated with increased risk of death. Next slide. Now, what is the mechanism? Tubular injury, acute tubular injury is one finding which was on autopsy studies was found to be the cause of acute kidney injury. In the post-acute phase, the majority of patients have resolution of that acute kidney injury, but reduced GFR persists at 6 months follow-up in patients, and that needs to be followed up regularly. Next slide. Again, these patients will need close follow-up, and appropriate treatment will be instituted. The endocrine complications. There have been some controversy about the development of diabetes as a new entity in these patients, and there are both studies showing positive and negative results. So it's still the jury's out, but worsening control of the existing diabetes is well recognized. Again, also subacute thyroiditis, again, multifactorial in nature, likely due to some immune dysregulation, and bone demineralization, possibly due to long-term immobility. Next slide. As I said, patients with newly diagnosed diabetes in the absence of traditional risk factors for type 2 diabetes have been reported. Pituitary adrenal axis and suppression of pituitary adrenal axis and hyperthyroidism is also being reported in these patients and should be followed up regularly. Hepatobiliary, next slide, hepatobiliary. Again, liver injury is, the incidence is between 14.8 to 53% in different studies, mainly results in elevated aminotransferase levels up to 3 times the upper limit of normal. Next slide. Liver biopsy specimens of the deceased COVID-19 patients indicate moderate microvascular steatosis, mild lobular and portal necrosis, inflammation, and fibrosis, etc. Next slide. Again, the more severe the illness is, the higher the chance of having a liver injury, and again, may even predict mortality. Next slide. The gastrointestinal long-term complications. Prolonged viral fecal shedding has been seen in some COVID-19 patients, even after negative nasopharyngeal swab testing. The likelihood of this is unknown, and the clinical value of this is still unknown. But COVID-19, next slide, COVID-19 has also the potential to alter the gut microbiome, including enrichment of opportunistic organisms and depletion of beneficial commensals, resulting in long-term diarrhea in some of these patients. Next slide. Again, we talk, so dermatological complications, a wide variety of different skin manifestations have been described in literature, and I wouldn't go through all those because there are at least 20s, if not 100, of these conditions have been described. But the most common are chilblain-like lesions, acroischemic, lividoid, necrotic manifestations as well. And these are likely due to the microthromboembolic episodes. Another manifestation, varicella-form like vesicular eruptions, is associated with the COVID-19, and it may represent the most specific manifestation of virus. Next slide. Hair loss is a predominant symptom and has been reported in up to 20% of COVID-19 survivor patients. This is next slide. This is a busy slide. It is a summary of the different systems involved and different symptoms of the complications. So I'll just go through it quickly. Next slide. This is just a figurative expression of the management of these patients. So for pulmonary cardiovascular symptom assessment at follow-up of 4, it has been suggested that they should be followed up at 4 to 6 weeks and at 12 weeks post-discharge. Patients who have dyspnea or persistent oxygen requirements should consider a 6-minute walk test, pulmonary function test, chest x-rays, pulmonary embolism workup, echocardiogram, and high-resolution CT scan on the chest as indicated by history and physical examination. For neuropsychiatry complication screening for anxiety, depression, post-traumatic stress disorder, sleep disturbances, and cognitive impairment is required. For hematological complications, consider extended thromboprophylaxis for high-risk survivors based on shared decision-making. For the renal complications, early follow-up with the nephrologist after discharge, and they should have early rehabilitation and education by the primary care physicians. Next slide. There are lots of questions which are still unanswered, and these are some of the. This is the a slide which shows some of the studies which are currently being conducted to answer these questions. So, for example, what are the long-term sequelae of COVID-19? There are several studies going on to answer this question. What are the immunological, enzymatic, metabolic, and radiographic predictors of post-acute COVID-19? Again, a few studies going on that. What are the long-term effects of COVID-19 on health-related quality of life? A few studies going on that. What are the long-term effects of COVID-19 on functional exercise capacity? And then there are studies, is there a role of anti-fibrotic therapy for prevention of development of pulmonary fibrosis and other respiratory complications in COVID-19 survivors? Another question which is being assessed is, does pulmonary rehabilitation improve pulmonary outcome in post-acute COVID-19 patients? Next slide. Another study is looking at a meaningful and does prolonged thromboprophylaxis leads to clinical meaningful benefit with regards to the venous thromboembolic events in outpatients with COVID-19? And do antiplatelets such as aspirin have a role in primary thromboprophylaxis in patients with COVID-19? Among the cardiovascular studies, they are looking at what are the median and long-term effects of COVID-19 on biventricular cardiac function. Neuropsychiatric, what are the physical examination and brain imaging characteristics in those persistent neurological symptoms in post-acute COVID-19? And what are the long-term psychiatric sequelae of COVID-19? In the renal studies that are being conducted, they are looking at what are the short and long-term renal outcomes and their predictors of COVID-19, etc. Next slide. So that is the conclusion of my talk. The references I have is from Nature Medicine, Circulation Research, Current Opinions in Neurology and Nephrology, Hypertension, Current Opinions in Nephrology, some other journals, BMJ, Clinical Respirology Journal, and clinics in dermatology. Thank you very much.
Thank you very much, Dr. Rehman. A brilliant talk on the complications of COVID-19. I think you summarized quite well the studies that have been done and the studies that are ongoing with regards to the complications, as well as the management of COVID-19. I think without further ado, there is some questions that were sent by some participants, and we can go on to those. And thanks, Visi. The first one is from Rick. Are there any treatments for long COVID?
Well, again, as I said, there are still studies going on. There are some suggestions. For example, anti-fibrotic treatment is being looked at in some research studies for pulmonary complications for pulmonary fibrosis. Long-term prophylaxis with the heparin or enoxaparin and oral anticoagulants is currently being investigated. I think at the moment, there are no answers to these questions. What we should do is that treat them as we treat other patients. Like, for example, patient with reduced left ventricular ejection fraction should be treated with AC inhibitors and beta blockers and spironolactone and all those things. So yeah, the important thing is these patients should be followed up. Because some of these patients will take it as a natural progression or natural sequence of the disease that may not consult their primary care physician. The important thing is that they should be assessed, they should be monitored, they should be investigated. Patient with dyspnea should have the pulmonary function test, should have CT angiogram, should have high resolution CT, etc., to assess the causes of these symptoms and then treat it appropriately.
Yes, I do agree, Doc. I think in the clinic that we have here at Sekitumile, Masiro Teaching Hospital, my experience is that, steroids as well as pulmonary rehabilitations, and most of the time, I advise patients to either buy a treadmill and we take them through an organized and progressive exercise program, or otherwise, gradual walking. And most patients tend to do well. The patients that are difficult to manage are those patients that are slow responders to steroids, or patient with overwhelming fibrosis and who require long-term oxygen at home. I think these ones are more difficult to manage because they need months and months of rehab before you can start seeing any sort of subjective change in terms of exercise tolerance. The next question, Dr. Rehman, from Dr. Bondeke, and it says most patients with COVID-19 have a high HbA1c. Is there any link between COVID and diabetes?
Yes, well, I think I've partly answered that question. There are two different point of views at the moment. Yes, one group thinks that there is a link. The other group thinks that there's no link. But yes, there's definitely more people have been diagnosed with diabetes while they have been treated for COVID-19. That may be just a higher screening in these patients, because most of the diabetic patients, or at least a significant portion of diabetic patients, are unrecognized. So these patients who come to the emergency room and then are admitted to the ward have their blood sugars checked and they are found they are high, and they are diagnosed with diabetes. Some of these probably will have diabetes for long time, which was unrecognized. But on the other hand, there are immune dysregulation of the whole body, and that can affect the pancreatic system, and the microvascular thrombosis may damage pancreas and cause problems with insulin secretion. There's a theoretical possibility, but the question has not been answered yet. I think there are studies going on this. So hopefully we'll have an answer in the next few months to this very important question.
All right. Thank you very much, Dr. Rehman. The next question is, what is the frequency of pulmonary thrombosis in COVID-19 positive patients? I think you touched on this during the talk as well.
Yes, 5% of the patients develop pulmonary thromboembolic disorder during their acute illness, but the proportion is likely higher in sicker patients, those patients who are admitted to the ICU, and those patients who require invasive and non-invasive ventilation probably have a higher incidence of pulmonary embolism. We do treat them with prophylactic enoxaparin, almost all of the patients who require oxygen, but the incidence of thromboembolic disease in post-acute phase is much less, but still significant. In one study, the incidence was 2.5%. So these patients, again, need to be monitored. Those patients who are complaining of shortness of breath after recovery from acute illness should have a high suspicion of pulmonary embolic disease and should be investigated appropriately and treated. The patients who are at higher risk of thromboembolic disease, like patients who have other comorbid conditions or immobility or cancer, there's a suggestion they may need long-term prophylaxis with enoxaparin or oral anticoagulants. The duration of this has not been determined yet, but it may be wise to continue prophylactic enoxaparin or anticoagulation till their risk factors are addressed.
All right, thank you, Dr. Rehman, for that response. The next question is from Michael Akerele. Which COVID-19 variant is currently most prevalent in Botswana? I can say that next week's talk, we will introduce it and it will be able to cover this question more fully and more appropriately, Michael. And then the next question, Dr. Rehman, is, which is very interesting actually. How do we manage patients or patients who develop post-COVID syndrome? The number is overwhelming. We know if there's been millions and millions across the world that have had, overwhelming symptoms. And then the prediction is that obviously in the next 5 years, because of things like pulmonary embolus, you're going to get pulmonary hypertension, especially chronic thromboembolic pulmonary hypertension. And we are seeing a lot of these thrombotic events. And you've mentioned, of course, the right ventricular dysfunction, which we also see here at Sekitumile Masiro. I don't know if you'd like to comment on that and what your thoughts are.
Well, I think it's a difficult question. In the next few years, there will be a lot of pressure on the healthcare systems because of COVID-19 and the lingering effects of COVID-19. You're right. These patients, even if 1% of these patients develop pulmonary hypertension, that will be huge numbers to cope with. And so are the other complications affecting different systems. For example, depression is quite common. 40% of these patients develop depression or anxiety after COVID. Lung complications are common. So it's a huge numbers, which the even developed countries I don't think are ready to, are prepared to deal with. And it is going to stretch our healthcare system. These patients will need a lot of financial input from the health systems to deal with them. And obviously, I mean, following them, investigating them, it will require lots of resources. So there's no single answer, but obviously depending on the system involved, these patients will require echocardiograms, these patients will require ECGs, they will require CT scans, angiograms, pulmonary function tests, and so on and on. And then the treatments will also be expensive. AC inhibitors for heart failures, beta blockers, steroids, antifibrotic treatments, anticoagulants, they will all cost money. So huge implications for the health costs in the next few years, I think.
Yeah, completely agree, Dr. Rehman. Thanks. And then I think the last question, due to the interests of time, is may people who have asymptomatic COVID-19 also present with long-term complications?
We don't know that. That's a very good question, but I don't think anybody has looked at that. Personally, I have seen patients who have presented with pulmonary embolism and without any obvious cause, and we were wondering if they had asymptomatic COVID, but the answer to this is still unknown. There have been reports of sudden deaths in people with COVID, and I don't know how frequent that is because we don't know how many asymptomatic patients might have died due to the cardiac rhythm abnormalities, but no other symptoms. So these are questions which have not been answered yet.
All right, no, very, very true. I do agree. There has been no answers, but it's been postulated that a lot of people will have some sort of complications, especially as Dr. Rehman has mentioned. It's going to be mental, psychiatric, depression, memory loss, which of course some patients already are exhibiting. I think another system that's been postulated or predicted to be involved as a long-term complication in asymptomatic patient is musculoskeletal. So, fatigue, on and off joint pains, and on and off, muscle aches.
Absolutely. Muscle aches, fatigue is very common in these patients. And it's we take it as any post-viral syndrome, but I don't think it's the simple post-viral syndrome. It is probably more than that, and will need a lot of resources to deal with.
Yes, completely agree, Dr. Rehman. I think just due to the interest of time, I'm going to ask Dr. Gaolathe to come and just close, talk about next week's topic, and then wrap up for us. Dr. G.
May I also take this opportunity to thank Professor Rehman on the topic for today. And we do hope we will have you as a presenter soon. Next week's topic, we're going to have a 2 series on variants of concern in Botswana by our own Dr. Sikhulile Moyo from the Botswana Harvard AIDS Institute. And I think as a follow-up, we will have another topic which speaks about variants of concern in general and vaccines, what we term a weather report by Dr. Simane Khasitsewe. So thank you for joining us today, and we hope to meet next week at the same time, 4 p.m. for our topic. Thank you.
Thank you very much. Thank you for having me.
Thank you.